having an ACO, acute coronary occlusion. So this is one more 52-year-old gentleman who came to OPD with severe chest discomfort, but the ECG was normal. There are no ST elevations in the ECG. So the angiographic reality is again the LAD proximal, almost osteoproximal is 100% occluded. So probably if the same patient would have gone to some other peripheral center and the ECG was done and where the troponin and echo was not available, probably he would definitely would have been prescribed, because there are no major ST changes, he would have been prescribed some proton pump and some syrup. Probably he wouldn't have come to any hospital next day. So this is one more man who went to the peripheral center where the ECG was done. So because there were little changes in the ST depressions in the precordial leads, so he was advised to consult a cardiologist. So he took his own time. He went the next day to cardiologist. He showed to cardiologist. The cardiologist advised an angiogram. Again, the result is same. The angiographic reality is completely different. LAD is 100% occluded with the thrombus. Luckily, for all the 3 patients, we were able to do PCI. But the important point is the ECGs were not showing any ST elevations in all the 3 occluded acute occlusions. So what do you take? How do you think? What is the sensitivity of the STEMI criteria to catch the acute coronary occlusions? So because I have showed some angiograms where there are no ST elevations and then the angiograms are showing LAD 100%, but most of us are practicing in a way that we are in fact seeing STEMIs with 100% occluded vessels. So let us assume that we have a sensitivity of around some 80% for STEMI to catch these acute coronary occlusions. So getting into this historical context, so previous to the STEMI paradigm, there used to exist this QF paradigm. The problem with the QF paradigm is it was not able to catch those acute, we are not able to save myocardium in fact with the QF paradigm. So this was a time when the mortality rates were higher, and this was a time when fibrinolytics were developed, and there were trials in fact with this fibrinolytic therapy and ST elevation myocardial infarction, and they found huge benefit. In fact, this was revolutionary at the time. The mortality rates have come down from double digit to low single digit. So, so with this, the ST elevation have become a surrogate marker for acute coronary occlusion. In fact, we almost forgot that there is an acute coronary occlusion. We were all concentrating on this ST elevation. Whenever there is an ST elevation, we need to treat. So, in fact, there were dramatic improvement with the outcomes, and a lot of quality metrics were developed with this thing like door to balloon time, ECG time and all. So, ST segment, not the acute coronary occlusion to be precise, the ST segment has become the gatekeeper. So, whenever a patient comes to the ECG emergency with a chest pain, do ECG within 10 minutes and just differentiate whether it's an ST elevation or non-ST elevation. When there is an ST elevation, yes, you need to go for immediate reperfusion. If it is non-ST elevation, yes, you have time to risk stratify, you check, and if you think you require, in fact, there were multiple trials showing that early versus late invasive angiograms in NSTEMI which didn't prove much benefit. So, this dichotomy is existing right now. This is the paradigm which we are living for the past 30 years. One is STEMI and the NSTEMI. We took it STEMI as an acute coronary occlusion and NSTEMI as non-occlusive. Assume it is no acute coronary occlusion. So, what is the angiographic reality? In STEMI cases, the angiographic reality is this. Almost 25% of the STEMI activations for the emergency are in fact not STEMI, they are in fact only the STEMI mimics. And if you get into the NSTEMI, 40% of the NSTEMI cases have in fact acute coronary occlusions which are not picked by the millimeter elevations in ECGs, that ST elevation. So, as I said before, what is the sensitivity for ST elevation to pick acute coronary occlusions? It is in fact less than 50%, that is 43.6%. Point is 56.4% of the cases we are not picking up with the ST elevation. So if you come with the vessels which are being missed, the L6 is the most common vessel which is missed, followed with the RC and LAD. So this is one of the study done, so which showed that 28% of the times NSTEMI has acute coronary occlusions, and that was not picked by the ECG in ST elevation. So should we believe in this dichotomy? Yes, the STEMI was ruling for the past 30 years. It did great work. It was revolutionary. There were much decrease in the mortality rates, but this dichotomy is in fact false. Why? Because this is not in fact matching the angiographic reality. Lot of NSTEMI cases also have acute coronary occlusions that are not being picked up by the ECG. So, right now, as with the QF paradigm, we have the crisis. Even with the STEMI also, we have this crisis. But the point is, we are not moving ahead of this STEMI and NSTEMI paradigm. We are just trying to fix it from within. So we gave new names to the STEMI to address this NSTEMI, like subtle STEMI, semi-equivalence STEMI, semi-STEMI and all. So the other part of STEMI is the no false negative paradox. What is this no false negative paradox? The point is, whenever you have a STEMI and acute coronary occlusion, yes, It's a true STEMI. Whenever you have a STEMI and no acute coronary occlusion, you call it as a false positive. Yes, you have this word false positive. But what if you have, you don't have STEMI and if there is an acute coronary occlusion? Yes, there is no name to it. You are comfortably calling it NSTEMI. So basically this STEMI doesn't have any accountability to say that there is no accountability. You are calling it by NSTEMI. So this is the false positive STEMI rates. Even these are high. In fact, 25 to 30% of the cath lab activations are in fact false STEMI mimics. They are not acute coronary occlusions. So there are multiple reasons why STEMI criteria fail to detect acute coronary occlusions. So probably the time we take the ECG or ST elevations may not be picked up. There are very small ST elevations or ST elevations are present in posterior leads where that is not seen in the anterior leads, or because of the collateral formation but the thrombus developing slow. So there are multiple reasons. So what is the, from the societies, what is the take from the societies? In fact, even the societies have accepted the crisis within the STEMI, but they didn't address it completely. Like you see in 2022 ACC or 2023 ESC, they told that, like, yes, there are significant minority of patients we are missing, but they didn't address it properly. So when was this actually taken? So it was in 2018, the OMI manifesto was given. This Smith and Mayers are one of the pioneers in addressing this occlusive and non-occlusive MI. So they asked for a shift. They asked for a move beyond the STEMI paradigm. So they coined this term occlusion MI. They said, stop seeing ST elevations, just see the artery behind the ECG, that is whether we are having acute coronary occlusion or not. So how do you define this? The definition is pretty simple. So the definition itself is saying that there is an acute culprit lesion, or there is a TIMI3 flow with a hugely elevated troponin levels or a regional wall motion abnormality. So why this paradigm shift is important? Because in the STEMI only we are looking at the ECG and the ST elevation. But in OMI and NOMI paradigm, we are just not looking at only ST elevation, but we are looking at other ECG patterns which in fact show acute coronary occlusion, not just the ST elevation. In fact, the assessment with the OMI and NOMI paradigm is dynamic. We are trying to catch more acute coronary occlusions than what STEMI used to catch. So what is the power of OMI strategy? If someone is really trained in this OMI strategy, if someone becomes expert, the sensitivity of catching an acute coronary occlusion is around 78% compared to the STEMI, which is only able to catch a 43%. So what is really important is not the elevation on the ECG, what is really important is the occlusion in the coronary artery which we are supposed to catch. But we are almost blinded by this paradigm for the past 30 years that we are just looking at the ST elevations. In fact, yes, ST elevation has done a really good job in catching, but it's not able to catch the other occlusions which the OMI strategy can catch. So with the OMI expert interpretation, as I said, the 41, when you see there is almost like 80% of sensitivity. So if you even take the negative likelihood ratio, the negative likelihood ratio for the STEMI is around some 0.5, but it is with 0.2 with the negative accessibility is better with the OMI. So what are those high risk? I'll just go through quick patterns of ECG which in fact were not showing ST elevations, but they in fact say that there is an acute coronary occlusion. So this is a quick reference of few of the things which we know. These are the names which you are given to the patterns like hyperacute, valence, and I'll go through these few of these things. So one is the hyperacute T waves. This is really difficult to catch. Anyone can catch those peaked T waves with a small base and peaking of the T waves like we see in hyperkalemia, but these hyperacute T waves are really important. They have broad base, they have rounded top, and the most important thing is like how much it is when comparable to the preceding QRS complex. So if you see this case is an LAD occlusive myocardial infarction, if you see really look at the ECG, we just think twice whether really there is an ST elevation in this case. But if you see in V3 and V4, there are T waves. If you look at the preceding QRS complex in these cases, it is definitely taller than the preceding QRS complex. In fact, this is the case of LAD occlusion myocardial infarction. And one very common thing which most of us know is the Wellens syndrome, type A and type B. And in the pattern A, basically, Wellens is an occluded myocardial infarction presenting later with a spontaneous recanalization, but still we have a critical 90 or 95% lesion in the proximal LAD. So I've shown two ECGs here. On the top left is the ECG where the patient presented with ST elevation. In fact, this was a pre-hospital ECG taken before the hospital, and the right one is basically the ECG which was taken when the patient reached the emergency. So if you can see, the ST elevations were there prior, but once the patient came to the emergency, there was little spontaneous recanalization. So there were biphasic T waves sitting in the V2 and V3. If you see a down ECG, there is one more ECG where there are biphasic T waves. People can easily get confused. This one with the can be a kind of Wellens, but if you see, this is a LVH strain pattern, where the biphasic T waves are sitting at V4, V5, V6 level, not at the V2, V3 level, where there are tall R waves. So this is a case of type B valence, where the deep T inversions in V2, V3, V4, V5, V6. So this is the other pattern of valence. So this valence type B, if you see at the down ECG, this also is like very pretty much similar to the valence type B, but this in fact is a pulmonary thromboembolism. So if you look clearly in a pulmonary thromboembolism, we generally, other than having this T inversions, generally we have other things like sinus tachy or T inversions in lead 3. So many a times we confuse pulmonary thromboembolism with a valence or occlusive myocardial infarction. We first do a angiogram and we see that there is nothing was there, and then we go back and search for the diagnosis and we find there is a pulmonary thromboembolism. So what is De Winter's pattern? In fact, the first one of the ECGs I showed in the beginning on the cases, one was the De Winter's pattern. So what is this De Winter's pattern? When there is an ECG with ST depressions in the precordial leads with a terminal T wave positive, so this was the ECG which I showed. In fact, this was the ECG. The physician outside told that to consult a cardiologist, but he was not very much thinking that it is an occlusive myocardial infarction. But if someone really sees an ST elevation, he would advise to go to cath lab directly. So what is this Aslanger pattern? This Aslanger patterns is something where there is a subtle, very subtle elevation in the lead 3 followed by depressions in the V4, V5, V6 and the inferior leads, other inferior leads. So the point is, this generally the upper posterior part of the left ventricle gets infarcted, and in fact the L6 or mostly the L6 is occluded and RCA. The point is the infarcts are in fact very large, but people tend to miss those subtle elevations in the lead 3 and they would probably diagnose it as end-STEMI and later the intervention would be delayed. So posterior occlusion MI, most of us know, typical depressions in the V2, V3, V4. If you take the posterior leads in the V7, V8, V9, we can catch those ST elevations. And one most important thing is the terminal QRS distortion. So this terminal QRS distortion, which we commonly call it as in C in benign early repolarization or pericarditis. So one very most important thing in assessing the terminal QRS distortion is loss of S waves in V2 and V3. So in the ECG, which is on the top, it is a benign early repolarization. We can clearly see, though there are ST elevations, J point elevations, we can see the S waves in V2 and V3. But if you see in the ECG down, that is in fact an LAD occlusion myocardial infarction, where there is loss of S wave in the V3. In fact, after doing stenting in this case, there was again the S wave came back in the lead V3. So Garbosa criteria, most of us know this Garbosa criteria. So criteria 1 and 2, most of us know. But what is this Smith modified Garbosa criteria? Previously it was the discordant ST elevation was taken as 5 mm, but we were missing a lot of cases. So if you see the CCG, if you look at the V4 and V3 in these cases, definitely we may not be thinking that the ST elevation is not greater than 5 mm. But if you calculate the ST by S ratio in this cases, it is 0.33. So anything greater than 0.25 can be taken as positive. So in fact, this case is a LAD occlusive myocardial infarction. So the other additional OMI patterns I won't discuss much. So one is South African flaxen precordial cell new onset bifascular block northern MI. So forget about the patterns. Basically, there can be a new pattern which they can say that there is a DS Langer's pattern where there is not an ST elevation in lead 3. There can be some other thing. But most important things is those ECG patterns which are important where it can suggest an acute coronary occlusion. For example, the most common things are in fact very subtle elevations, not any patterns, like reciprocal ST depressions without any elevations. These are the most common patterns in fact showing acute coronary occlusions. So what is the evidence? So the evidence is these were the pioneers, Alankar, Hillinger, Kahn, Mears and Smith. These were the pioneers who in fact said that STEMI in fact was less sensitive in diagnosing the acute coronary occlusions. So I would just go through quickly through this Mears study. So this Mears study is about 334 patients. The quick data is like almost 40% of the patients without ST elevations had acute coronary occlusions in his study, almost 40% of the patients. So the point is the median ischemic time difference between a STEMI acute coronary occlusion and a non-STEMI, that is STEMI negative acute coronary occlusion, is this difference, 41 and 437 minutes. So if you see the complication rates or PCI rates in these people who are acute coronary occlusion STEMI and no STEMI, in fact both are same. So both required the similar amount of, both had similar complication, but the only problem with this, because it was end-STEMI or because it was diagnosed as end-STEMI, his treatment was late. So the summary was similar angiogram, similar PCI rates, similar complication rates, but significant delays in STEMI negative occlusive myocardial infarction. So how does AA help here in this OMI? So not everyone can become an OMI expert. There are many cases like it'll be really difficult to activate the cath lab when you see some minimal depressions and thinking there is an occlusive vessel. So what is the role of AA here? So this is one study which was published just in the last one, Jan 26, in the JACC interventions. So this this study was done with the Queen of Arts PM Power Medical Cardio. So this was done in 3 centers in Boston, Houston, and Texas. So out of 1,085 patients were taken for the 3 years, and in those patients, in fact, 601 were true STEMI and 431 were STEMI mimics, the false positive cases. In fact, the cath lab was activated 41% of the times for mimics, STEMI mimics. So if you compare these results, if you compare this true STEMI and STEMI mimics, so basically for LBB or QRS greater than this, it is more of a STEMI mimic. So the important point is a STEMI equivalent. So out of 601 patients, 238 patients had LAD occlusion or some other vessel occlusion, acute coronary occlusion, but there is no ST elevation. There is no ST elevation. They found it because he was people are OMI experts. They were able to find this 238 patients who didn't have ST elevations, but they thought that there were acute coronary occlusions. So these are STEMI equivalents. And in fact, among these 238 patients, only 58% of the people have in fact got an immediate cath lab activation. So how AAECG will, so they did a retrospective analysis on all these people. So it's the AAECG is very simple. You just need to put that ECG in the phone or somewhere and then you'll get a result within 10 seconds. So how this ECG, AAECG compared with the OMI expert? I'm not telling about the STEMI criteria, about the OMI analysis. OMI analysis is able to catch 71 to 80% of the times, but the AAECG model is able to catch occlusive MI 92% of the times. So this is a specificity. So even if you take across multiple subgroups, compared to the standard of care, AA sensitivity is very, very high. It's more than 90%. So similarly in false positive activations also, it is very high in classifying their STEMI mimics. So this is a real case example where this was 77 years old lady. This was published in that study. So this was the ECG. The ECG was not showing any ST elevation in fact, so they were not activating the cath lab. So in fact, this particular lady had almost a 368-minute delay after, after troponin, everything was done. So it almost took her 6 hours to get into the cath lab. So, but when this ECG was fed into the AECG model, it gave an immediate result. It told that it was a STEMI equivalent. In fact, that patient had a 100% thrombotic costal occlusion. So, compared to the previous ASA model, this one is a Queen of Hearts model improved version. This had a better sensitivity. So clinical implications are definitely, what we can tell is with this OMI ECG patterns, if AA is associated with the OMI ECG patterns, the sensitivity can be much better and we can catch better acute coronary occlusions. So the most difficult part is the implementing this OMI paradigm. So we need to shift our focus from just looking at the ST elevation. We need to, it's just a conceptual shift. We need to look at the acute coronary occlusions instead of ST elevations, but it's very difficult to catch if you have the support of AI. So, and with support of AI being looking at the acute coronary occlusions, we can catch more ACOs. So, final conclusion, the STEMI paradigm is outdated. We must shift from ECG surrogate markers to pathophysiology-based classification. The ICOMI paradigm plus AA tools offers the next evolution in ACS care. Thank you.
Thank you, Dr. Anup. As we are running behind the schedule, if the last one question by the panelists, if any, or else we'll move ahead, sir.
Yes.
Sorry, yes. There are a lot of ECG markers or ECG changes which we cannot remember those things, like you said, terminal modification of QRS complex, height of QRS complex when compared to the T wave, all these things